So we'll be moving to the next segment of the session today. That is the college lecture, which is supported by the Zydus Hemas Pharmaceuticals. And today's lecture will be delivered by Dr. Chiranthi Liyanage, MBBS, MD, MRCP UK, MRCP UK Rheumatology, and consultant in rheumatology and rehabilitation. And she is presently senior lecturer in pharmacology at the Faculty of Medicine, University of Colombo. Her research interests are medication safety, pharmacoeconomics, pharmacogenomics, and gender equality. So she'll be talking to us about systemic sclerosis decoded. Over to you, Chiranthi. Thank you for being here.
College of Physicians for giving me this opportunity. So I thought that I'll talk about systemic sclerosis for a couple of reasons. It is a relatively new disease compared to, let's say, diabetes, which has been described somewhere in the 1500 BC, or tuberculosis, which had been found in the mummies from ancient Egypt. This is relatively new because the first documented report comes from the 1750s. And the name scleroderma has come into use from the 1800s. But it's rare. The incidence is about 10 to 20 per million per population per year. However, this is the CTD with the highest, this is a CTD with the highest case-specific mortality thus far. And there is a significant lag time from the time of developing the first symptoms, which is usually Raynaud's, to diagnosis. It's at least about 5 years in majority of cases. So because of this, I thought that I'll draw on my experience as being trained in the largest scleroderma center in the UK and try and answer 5 simple questions. Number 1, do we need to diagnose it early, and why? And how do we diagnose it early? And what will happen if we don't? 4th, so how do we manage these patients? And number 5, in Sri Lanka, what can we offer these patients? Is there a different Sri Lankan perspective? So let me first share the story of this patient that I met as a senior registrar in rheumatology. She was from the Gampaha district, having these skin changes, a tight skin in the face, big-shaped nose, difficulty in opening the mouth. She had very tight skin in her fingers, difficult to grip, and she had these pitted ulcers, which were quite painful in pulp. She has been bouncing from place to place for a couple of years, diagnosed, but then within a short period of time, she had severe features of Raynaud's and developed gangrene of her toes and got admitted. And in her HRCT, this is her image, you can see the lung fibrosis with traction bronchiectasis. We did a 2D echo and she had severe pulmonary artery hypertension as well. So if we look at this young lady who was just in her late 30s, I would say that we will be able to offer her some treatment, but it would most probably be very little too late. So to understand why we should diagnose this disease early, we need to first of all have a basic understanding about the disease pathogenesis. So as with all autoimmune diseases, there's a person with a genetic predisposition, and when they're exposed to some environmental factor, usually it could be an infectious agent or an immune-mediated cytotoxicity or some form of injury, there is loss of tolerance in the body. And earlier there was a question of whether we've seen an increase of autoimmune diseases following COVID vaccination or COVID infection. We have seen multiple cases of worsening systemic sclerosis or new onset systemic sclerosis after vaccination or infection. So with this, one of the first things to happen is endothelial damage. And when there is endothelial damage, there is impaired vasodilatation, and there is also defective angiogenesis that happens. Along with that, there are immune abnormalities that happen, primarily involving the macrophages, the T cells, and the B cells. And with that, with the macrophage fibroblast crosstalk, there is increased amounts of extracellular matrix that is laid down. And the normal fibroblasts get converted to myofibroblasts that lay down more and more extracellular matrix, and there's a fibrosis that happens. So this shows the different types of cells involved. There are so many different inflammatory mediators that are thought to play a huge role in the development of systemic sclerosis, particularly TGF-beta. And so ultimately, with time, you get a fibrosis that happens in the skin and in the internal organs. So essentially, in systemic sclerosis, we see three main things. There is autoantibody formation, there is a microvasculopathy, and there is fibrosis of skin and or internal organs. However, there is a clear early phase where it is much more inflammatory, with more reactive oxygen species, more inflammatory mediators, and more vascular changes. And with time, the fibrosis sets in, and the fibrosis starts to become more prominent, and the inflammation subsides. So quite often when we see patients, we see features of all these three main things. We see a little bit of immunological abnormalities, some fibrosis, some vasculopathy. So from an immunological point of view, we get our autoantibodies. So we all know that the classical ones are SCL70 or antitopoisomerase, anticentromere, and antipolymerase 3. Vasculopathy, we get Raynaud's, and we also get an obliterative vasculopathy, where there is occlusion even without the vasospasm. Then we get internal skin involvement as well as internal organ involvement of multiple organ systems and the skeletal system. And classically, this is divided into the limited form, where you get skin involvement distal to the elbows and the knees. Face could or could not, may or may not be involved. And then we get the more diffused form, where there's skin involvement in the chest and the truncal area. And then we have the systemic sclerosis sign scleroderma, where you don't see the skin involvement, but all the organs can get involved. And the other entity are the overlap syndromes that we can get. Now, the two disease entities, why is it important for us to differentiate? It's because the disease causes are a little different. How they progress are different. In limited disease, we get a long-standing Raynaud's, and they slowly start to develop the skin involvement. They don't get a lot of constitutional features unless there is internal organ involvement. They can get calcinosis and severe Raynaud's and complications of that. However, with time, they can develop GI involvement, which can be quite severe. Lung fibrosis, again, is sort of slowly progressive. But if they're SCL70 positive, they can get pulmonary artery hypertension even without lung fibrosis. And the risk of renal crisis is rare unless they are anti-RNA polymerase 3 positive. So this shows the classical perioral skin loss, perioral fat loss. And you can see the beak-shaped nose and the very tight skin, the sclerodactyly, and the skin involvement is only quite limited, and you get the calcinosis cutis, and here you can see the capillary changes. In diffuse disease, it's more rapidly progressive. So that from the point of onset of Raynaud's to their skin involvement is quite short. And they will have more systemic features. They will have more and more musculoskeletal problems, including friction tendon rubs. They can develop GI involvement just like in limited disease, but they have a very high risk of cardiac involvement and respiratory involvement, and the renal crisis is particularly high in the first 5 years of their disease. So here again, you can see the puffy hands with limited flexion of the fingers. You can see their typical faces, and this is in early disease, particularly in RNA polymerase III disease, where you get this indurated skin that is red. You can get flexion contractures, and you can see the telangiectasia here, and the very tight skin in the extremities. So the other disease and other types that we see are the overlaps, and there are a few classical overlaps that are described, and we can predict the ones that are going into overlaps depending on their antibody profiles. So if a person has all these features, it's pretty much a spot diagnosis. However, if this is the point that we are diagnosing patients with systemic sclerosis, this is way, way too late for that patient. So we don't have a diagnostic criteria for systemic sclerosis. It's a classification criteria that's intended to be used for research purposes to get a homogeneous group of patients. But we can use this if we are in doubt to identify patients. And even in this, you have to get 9 or more if you're going to go by this criteria. And if you're going to wait for the skin to be thickened, if you're going to wait for the fingertip lesions to occur, if you're going to wait for interstitial lung disease to occur, it might actually be too late. And this was published in 2013. We can see that in the studies that have even used the 2013 ACR criteria, the treatment does not do much. The patients who are on treatment actually do better than the patients who are not on any treatment. That's the purple line, the placebo, which has looked at skin involvement here. And they have included patients within 3 years of the onset of skin thickening, but still there's no significant difference. And in this study, they have concluded that it may support using immunosuppressants in early diffuse systemic sclerosis. So this shows us that we actually need to diagnose these patients early. And why don't we have a lot of evidence for treating systemic sclerosis? And why is it that we say that we don't have effective treatment? It's quite possibly because we are picking up these patients too late, when their fibrosis has already set in and when their inflammation is subsiding. So that brings us to the next question. So how can we pick these patients up early? With this in mind, because of this, there was a model that was proposed where they said there is a possibility of very early systemic sclerosis where you don't see the skin, but you have Raynaud's, you have antibody positivity, and you might have these capillaroscopy changes. And then you have early systemic sclerosis where you get the puffy fingers and the digital ulcers. And then when there's established disease, that's when you start developing all the features of tight skin, lung fibrosis, fibrosis of the heart, etc. So this, they put forward as a criteria in 2009. And this cohort was followed up and they finally published in 2021, where they advise that if a person has Raynaud's, ANA positivity, and they have puffy fingers, these should be considered as red flags for early diagnosis of systemic sclerosis. And if they are picked up at that point, they need to be referred to be evaluated. And when they're referred, we can do a nail fold capillaroscopy. If we have the facilities, we can do the specific antibodies and come to a diagnosis. And it'll be interesting that for you that if they fulfill these criteria, they actually fulfill the 2030 ACR criteria as well. And in Raynaud's, in patients with Raynaud's, if they don't have ANA, that's one of the most predictive factors for not developing systemic sclerosis. And if they have one or two of the initial red flag signs, it confers a higher risk of progressing into systemic sclerosis over time. So our aim should be to identify these patients who are quite early and then refer for further evaluation. And capillaroscopy is a very simple thing that we can do with a handheld device, where we can identify classical features that we see in systemic sclerosis, as well as sometimes in other rheumatological diseases like myositis, where we see these giant capillaries. We might see capillary dropouts, as we see here. There might be microhemorrhages. So it doesn't cost us anything. We just need a device. It's not very expensive. Of course, the dermatologists use a dermatoscope, which is quite expensive, but for rheumatologists, we don't need such fancy dermatoscope. A simple device that has a magnification of just about 1,000 would do. So this, if we can pick up these patients and refer, we can actually diagnose them early and intervene early. So what if we don't? What if we let it linger, as what has happened to the patient that I described to you before? Systemic sclerosis can affect basically any organ system in the body. It can affect your heart, your lungs, the kidneys, the gastrointestinal system, and what you can see outside your musculoskeletal system and the skin. So one of the main reasons, one of the main causes for death in systemic sclerosis was scleroderma renal crisis. So it is more in patients with diffuse disease and more in early stages of disease. So if you see a person with diffuse systemic sclerosis, particularly anti-SCL70 positive, who are getting oligorenal failure, who have got features of MAHA with the thrombocytopenia, usually their blood pressure is high, but can be normal. You need to really suspect scleroderma renal crisis. And the mainstay in treating these patients is with ACE inhibitors or ARBs. Pulmonary involvement, again, about 80% of these patients will develop it at some point. And it's usually a non-specific interstitial pneumonia. However, they can have pulmonary vascular disease as well, and they're at a greater risk of aspiration with the GI involvement. It can involve any part of the GI tract from the esophagus to the anus. And this can be quite debilitating, and it tends to progress with time. In addition to that, cardiac involvement is now one of the main causes of death in patients with systemic sclerosis. However, we see that we tend to recognize it late, and any part can be affected. And sometimes they present with classical angina, but when you do an angiogram, you don't see any lesion, because in those cases, it's due to microvascular coronary artery disease, where they do get spasm of the coronary arteries, like what you get in the peripheries with Raynaud's phenomenon. And arrhythmias, particularly tachyarrhythmias, are a real problem in these patients, where they can go into sudden cardiac arrest. And over time, we have seen a change in the causes of death in these patients because our treatments have changed. In the 70s, it was primarily the scleroderma renal crisis. But as we started learning more about the disease and started using ACE inhibitors or ARBs, the mortality of that has come down. Then was pulmonary artery hypertension. It started going up as we started treating scleroderma renal crisis better. But with the advent of phosphodiesterase inhibitors and endothelial receptor blockers, that is also coming down now. Then the main cause of death now for patients with systemic sclerosis is pulmonary involvement, pulmonary fibrosis. In addition to that, we are seeing patients with multi-organ failure, And it's particularly because their lifespan has increased. They're living longer, and because of that, they're getting more and more organ involvement with time, and we are seeing these multi-organ failures coming up. So if the disease is so complex, it can affect any part of the body, how do we manage these patients? Number one, the first principle, as I think Maheshika said, with all autoimmune diseases, is early diagnosis. And at the point of diagnosis, we need to do a baseline to evaluate which organ systems are involved, and a management is based on the organ systems that are involved. These are organ-specific management plans. And with that, we need to devise a follow-up and monitoring plan as well. So I'll go through some of the key features, key management points, emphasizing on things that have changed, particularly from the publication of the 2017 EULAR guidelines, because a lot has changed with new trials coming up. So coming on to skin involvement, number one, this is something that we don't often do here, but it doesn't cost us anything to do a proper assessment of the skin involvement and document it so that we can monitor these patients. And what we usually use is the modified Rodin skin score, which is assessed in 17 areas. The maximum score that you can get is 51. So how do we manage skin? We need to start treatment as soon as possible. We should not wait for thinking that it's just the fingers, it's just the hand. We need to start early, because there is that if we catch them in that inflammatory phase, it is reversible to an extent. And earlier, methotrexate was preferred, but now more and more evidence is coming up for mycophenolate, and currently we tend to use mycophenolate as a first line or methotrexate. And there is a lot of evidence for using cyclophosphamide, rituximab, and even tocilizumab in severe skin involvement. And in refractory cases, even IVIG can be tried. Raynaud's, nothing much has changed here. It's just mainly calcium channel blockers, and we can add on phosphodiesterase inhibitors, intravenous prostacyclines, mainly used in the West. We don't quite often use it here, and it's not available either. And then a combination of that and other things like GTN, angiotensin receptor blockers, fluoxetine, sometimes botulinum toxin injection, and if they are refractory, even digital sympathectomy can be done. And coming on to one of the main killers for patients with systemic sclerosis, the first thing, as I told you, is to detect it early and properly evaluate and stratify their risk, and we can start immunosuppressive therapy. If it's NSIP pattern, there is always a place to start immunosuppression. If it's just UIP, it's probably a combination of immunosuppression and antifibrotic therapy. So again, for oral medicines, MMF and azathioprine is there. We can give cyclophosphamide. Rituximab, there are about 3 or 4 randomized controlled trials that have been published recently showing very good reduction in the progression of lung fibrosis. And tocilizumab has been approved by the FDA in 2021 to treat lung fibrosis in systemic sclerosis. And as for antifibrotic therapy, nintedanib, we do have it. Pirfenidone is being tried out. So, and in the West, there are patients who are selected and referred for autologous human stem cell transplantation, but those are very selected cases sent only in specialized centers. And pulmonary artery hypertension, again, it is based on your initial risk stratification. And earlier, we would just try and manage with a phosphodiesterase inhibitor. And strategy was, if their symptoms can be managed with phosphodiesterase inhibitors, we wouldn't really think much about it. But now that has changed, because we've seen that if you aggressively manage pulmonary artery hypertension to reach a target, like we do with all autoimmune diseases, their mortality improves. So unless there's a contraindication, even low to intermediate risk patients, now the current recommendation is to start an endothelial receptor agonist along with a phosphodiesterase inhibitor. And IV prostacyclines can be added in very high-risk patients, and these are usually given every 3 weeks or 4 weeks. So all this, and the screening and the follow-up and the monitoring, we can customize it based on the patient's profile. And in the West, we do this by looking at the patient's autoantibody profile. We can predict which ones are going to develop which organ-specific complication. For example, if they are diffused systemic sclerosis with antitopoisomerase, they're very likely to develop interstitial lung disease. So we will monitor them much more frequently for lung complications. Pulmonary artery hypertension is much more common with anti-U3-RNP. And scleroderma crisis is more common with anti-topoisomerase, that's SCL70, and antipolymerase 3. So in these patients, we actually advise them to monitor their blood pressures at home at least twice a week. So this is what we do in the UK or in the West. And things have changed, and the mortality is improving, the survival of these patients are improving. And what about us? What about in Sri Lanka? Our patients are different from the Caucasians and the African Americans that we see, because Asians are known to have younger onset of disease, so that the onset of Raynaud's is at much younger age, and they progress much quicker to develop non-Raynaud's manifestations much earlier than Caucasians, but not as early as African Americans, but earlier than Caucasians. And they have a high prevalence of anti-topoisomerase antibodies and U1-RNP and anti-RO. And anti-U1-RNP in Caucasians confers a better prognosis, whereas in Asians, it's the other way around. And we have a lower frequency of other antibodies. We have a lower incidence of Raynaud's. This is not just due to the climate. Even Asians who are in colder climates are found to have a lower incidence of Raynaud's. And they have more frequent diffuse systemic sclerosis and more frequent lung involvement. And with all this, Asians have a higher mortality compared to Caucasians. African Americans anyway have a high mortality. They progress very, very rapidly, and we are on that same line. And the leading causes among Asians is pulmonary hypertension and infections. So we should ideally be diagnosing them early, evaluating them early. We need to have more intensive monitoring with risk stratification and early intensive therapy, trying to stop this progression. However, as the previous speaker also highlighted, we don't have access to investigations. We don't have medicines, or the quality of the medicines are not assured, or we have so many problems. And there are so many socioeconomic factors that contribute to late presentations, loss of follow-up, poor adherence to medicines, particularly in a crisis situation as we are in today, because people have much bigger problems than their skin getting thick sometimes. And our health system itself is not very conducive to having a proper referral system or having a proper shared care for these patients, because they do need a multidisciplinary team to properly manage them, which we don't really have. And all the data that I showed you about Asians, none of it is coming from Sri Lanka. There's one study in India. All the other data comes from large cohorts in the US, Europe, and UK, where they have included multi-ethnic cohorts of patients and analyzed the subgroup of Asians. So we don't have any local data on the disease course or the progression or response to treatment. And we know that there are significant pharmacogenomic variations, particularly in immunomodulatory therapies, even in Sri Lankans. So how do we then get about it? We need to start somewhere. We need to come up with some plan and work within our constraints to give the optimal care that we can for these patients. So number one, if there's any doubt, have this in mind, recognize it, and refer for further evaluation. And once referred, we need to try our best to do the baseline investigations and risk stratification with whatever that we have. Monitoring, yes, we do need investigations, but a lot can be done clinically. If we are all trained to be clinicians, if we have a stethoscope, if we have our ability to examine and our 5 senses, there's a lot that we can do, even without any investigation, to monitor and follow up these patients. And earlier, the thought or the thinking behind managing patients with systemic sclerosis, that it's as good as giving a death sentence, that the mortality was so high, the morbidity was so high. But now we know that if we catch them early, intervene early, there's a lot that we can change. There's a lot we can do to improve their quality of life as well as to prolong their survival. So we need to start treating them with whatever that we have. If we don't have access to MMF, we can try methotrexate. So, and the other thing that we really must push for are collaborative cohort studies within the country, because this is a rare disease. Doing a study at NHSL alone, we won't catch that many, but we need island-wide participation from all centers to get a good cohort of patients and follow them up prospectively to see whether we are as the same as other Asians, or do we have any specific features that we need to think of as Sri Lankans? How do we respond to treatment? And of course, all this will take time, but every small step counts. So we need to start somewhere to make a big difference. Thank you.
Yeah, before start of the questions, just a small reminder that our sessions will be 2 weeks away. Please register online. Yeah, most of the sessions are actually getting full now. So do be quickly. Any questions, anybody? All are hungry. So thank you very much, Chiranti, for taking part in leading this